Hi, good evening all. I welcome all of you on this relaxation Sunday, and it's a great honor to welcome Dr. Jayanti Thumsi, who is currently working as a lead surgeon breast oncology at Apollo Hospital, Bannerghatta Road, Bangalore. Dr. Jayanti Thumsi has graduated and completed her MS in general surgery from Grant Medical College, JJ Hospital, Mumbai. She has undergone training in breast oncology at Tata Memorial Hospital, Mumbai. She has been practicing breast oncology in Bangalore for the past 21 years and has a very vast experience. She has performed more than 3,500 breast surgeries and 2,500 other surgeries so far, with an expertise in breast conservation and breast reconstruction surgeries. She has been interested in bringing about awareness in women about breast cancer and has been very active in conducting more than 258 awareness programs. And she has educated nearly more than 4,000, no, it's actually unit 10,000, 10,000, 45,800. Like 40, yeah. Unit turns 100,000, 10,000 lakh. Yeah, sorry. It's 4,58,000. Yeah, absolutely. So far, she has done a number of TV shows, radio programs, written newspaper articles, YouTube videos, Facebook live programs, etc. She has authored a book, Lum to Laughter, which highlights the emotional journey of women going through breast cancer treatment with medically validated information. The book is already in its third edition. She has been honored with so many awards. One is Women Achiever of Karnataka in 2019 by VRL Group, Vijayvani and Digvijay TV also, Kengal Hanmantaya State Award in 2019 for her work in the field of breast oncology and her contribution to the society. She has also won Chanakya National Award, Jury Special Award for Medical Inspiration by Public Relations Council of India and World Communicators Council on 6th March 2020. She is a founder member of Crest Foundation, and also she is a managing director, which is an NGO working on reducing the burden of cancer in our society. Under her leadership, Crest Foundation has collaborated and organized the world's largest campaign for breast self-examination, in which about 2,332 women were taught breast self-examination in a single day. So this event was a world record and has been recognized by Limca Book of Records. Crest Foundation has sponsored education for 3 deserving, meritorious but underprivileged students for completing MBBS. Dr. Jayanti has published many papers in various national and international journals. She has been an invited speaker in many national and international conferences. She is also involved in many research activities and clinical trials. Here I welcome you, ma'am. Sorry for that wrong number.
Good evening, everybody. Thank you so much for the elaborate and introduction. It's a great pleasure for me to be here to talk to all of you. I've met few of you in the past, and it's good to see all of you again. And finally, we are doing some physical meetings, and I'm sure we were all tired of the virtual meetings that we had. So today, I'm going to talk about something very basic, which I think will help you in your practice. How to go about a patient who comes with breast-related problems. So I'm going to talk about the basic stuff which I think will be useful for you, and also a lot about benign breast diseases, which is more common than breast cancer. So let us begin. The topic that I am going to speak on, this isn't working. Right, so the topic that I'll be speaking on is breast cancer, is it a cause of concern? So as clinicians, we all come across women with breast disorders very commonly. They may be benign or they may be malignant. Most of them, that is 80% of them, are benign. They are non-life threatening and may not need any treatment at all. And most benign lesions do not progress to cancer. In contrast, we have breast cancer on the other side, which could mean loss of a part of the breast or full breast, and sometimes loss of life. So as clinicians, it's important for us to distinguish a benign breast disease from in situ and invasive breast carcinoma, to assess the patient's risk of developing breast cancer in the future, and to establish the most appropriate treatment modality in that particular patient. So I'll just present in the form of a case. This was a 23-year-old unmarried girl who came to us. She noticed a lump in the left breast for 8 months. She consulted few doctors in the past. Ultrasound breast was done, which showed it to be a fibroadenoma. Hence, it was left alone. She was asked not to worry about it. But the lump, which was small in size, began to grow, and it gradually increased in size. And when she was referred to us, she had a 5 into 3 centimeters lump with left breast and a left axillary lymph node. She had no family history of breast cancer. Now, when such a patient comes to us, how to go about? What do we do when a patient comes to us with breast-related problems? So one thing most important to remember is triple assessment. If we do the triple assessment, the chances of getting an accurate diagnosis is 99.99%. So what are the factors of triple assessment? One is clinical diagnosis, which would mean a detailed history taking and a thorough physical examination, imaging, and also tissue diagnosis. Now, when all the three modalities are combined, then the chances of getting the accurate diagnosis is high. Unfortunately, if one of them is also left out, that is when it leads to problems. In history taking, history of breastfeeding, menstrual history, age of menarche and or age of menopause, age at first childbirth, family history of malignancies, history of previous mammogram or history of previous breast biopsies, and history of taking oral contraceptive pills or HRT. What to examine? It's important that you examine both the breast. The extent of the breast is from clavicle to the upper part of the abdomen. It's important that you feel the breast below the clavicle. There may be lumps which could be missed if we do not palpate that part. And from midline to the mid-axillary line. Along with bilateral breast examination is also important to examine the axilla to look for any lymph nodes. Also important to examine the supraclavicular region and the cervical region for lymph nodes if they are present. That can give us a clue as to what the problem could be. When we are palpating, there are some differences that we need to know, which could differentiate from benign to malignant. The firm, painful, or smooth or mobile lumps tend to be benign. However, hard, painless, irregular, and fixed lumps tend to be malignant. No skin dimpling or discharge, which is discharge from the nipple, which is greenish or yellowish or milky, tends to be benign, but bloody discharge could mean it's a malignant lump. And no nipple retraction, often seen in benign, but nipple retraction is a sign of malignant breast lump. How to investigate? What are the imaging diagnostic techniques that we use? The diagnostic modalities are in radiology, we do mammogram, ultrasound, and MRI. And in pathology, we do FNAC, core biopsy, surgical biopsy, and cytology of the nipple discharge. In breast imaging, there are unfortunately limited options in young patients. I have seen that even in a very, very young patient, often a mammogram is asked for as a routine. It does not help. Mammogram does not help in women who are less than 40 years of age. Post-menopause is the best time when mammogram gives us the most information. So as a routine, in a young patient who is less than 40 years, mammogram need not be asked unless clinically there is a suspicion of malignancy. So in such patients, ultrasound of the breast would be the right investigation. However, if there is a clinical high risk of malignancy in women who are less than 40 years of age. Yes, we would do a mammogram along with ultrasound of the breast. Like I said, sometimes mammogram may not be informative. In such women, we would ask for a breast MRI. Breast MRI is high on sensitivity but low on specificity. So ultrasound alone for women who are 40 years and above, only ultrasound is not enough. We need to do a mammogram. Along with that, ultrasound is done for women who are 40 years and above. Again, this isn't working. Okay, so mammogram has revolutionized the management of breast cancer. We see 44% less mortality because of mammogram. It is routinely not done for women who are less than 40 years of age. Please do it for all the women who are more than 40 years of age, and always, always bilateral mammogram has to be done. This is another thing which everybody should really remember. Just because a patient comes to us with a lump in one side of the breast, doing mammogram only on one side is not enough. Certain breast cancers tend to be bilateral, they may be multicentric, and doing a mammogram of the other side is equally important. So this is how a mammogram looks like. This is a benign breast disease. You can see it has a smooth margin, but this is how a malignant tumor looks like. You can see this. In histopathology, there is always a confusion whether to do FNAC or a core biopsy, right? So FNAC, friends, is only a cytology. As the name suggests, it's a fine needle. It's a very small, thin needle which goes into the lump, and when we aspirate, only few cells can be aspirated, and very often to give a right diagnosis on that may not be possible. So if a FNAC is negative, it does not rule out malignancy. The better investigation could be a core biopsy. Core biopsy is something very, very easy. It can be done even in the clinics. Maybe sometime in the future we can have a hands-on training on that, and I will be happy to help you all in that. It's a very simple procedure which all of you can do it. And core biopsy can give us, it's a histopathological diagnosis that we get, and along with that, the immunohistochemistry markers which we need to do before starting a treatment for breast cancer patients can be done on a true cut biopsy specimen but cannot be done on FNAC. Of course, when a patient comes with nipple discharge, cytology can be done. Again, negative cytology does not rule out malignancy. So 80% of breast lumps are benign. So I'll in short tell you a little important things about the benign breast diseases, which is more relevant, I think. So breast abscess, it can be lactational or non-lactational. Now lactational breast abscess, the best modality of diagnosis is ultrasound. Give antibiotics, try to aspirate the pus as much as possible with a thick bore needle. Sometimes if aspiration does not help, surgery might be needed, especially in the abscesses which are more than 5 centimeters in size or which are multiloculated, which again can be known on after doing an ultrasound and if aspiration has failed. However, if it is non-lactational, which we see very commonly these days, granulomatous mastitis, in those cases, tuberculosis has to be ruled out and surgery with or without steroids help in such patients. Pain in the breast or nodularity in the breast is something very common. I'm sure all of you will agree. Many of the patients come with a complaint that there is pain in the breast. It could be cyclical mastalgia. Again, ultrasound of the breast will help. But remember, anybody who is more than 40 years, please get a mammogram done even if it's clinically a fibrocystic disease. Ultrasound will help differentiate between a cystic and a solid lump. It can also tell us if the wall is thick, if there are thick septae, and if there are solid echoes in that, which could be a complex cyst. Again, that could raise an antenna saying we would like to rule out malignancy in such a patient who has a complex cyst. If it's a large cyst, a simple cyst, aspiration itself helps. And when you aspirate, please notice the color of the aspirate. If it is non-bloody, you can safely discard it. But if it is bloody, please send it for cytology, and it could mean that more investigations are needed. So treatment, aspiration itself causes a lot of relief, reassurance, analgesics, oral contraceptive pills, evening primrose, vitamin E, danazol, tamoxifen, many have been tried. Usually surgery is not needed in these patients. However, if there is any suspicion on cytology, if there is suspicion on radiology, and in spite of aspirating and trying all medications, if the cyst persists, in those cases, a surgery may be indicated. Fibroadenoma is very, very common. 15% of them tend to be multiple and 10% are bilateral. Majority of the fibroadenomas do not need surgery. Just because there is a fibroadenoma, surgery is not needed. Surgery is needed only when the fibroadenoma is growing, which is more than 3 centimeters in size, and it is painful. A giant fibroadenoma is something which is more than 5 centimeters in size. If you see a patient with the phylloids is basically a pathological diagnosis. That means we operate on a patient thinking it to be a fibroid. We send it for pathology, histopathology, and the pathology turns out to be phylloids. Phylloids could be benign, intermediate, or malignant, and they tend to recur. If you see a patient who comes with a histopathology of phylloid, you need to sensitize them and tell them that there could be a recurrence. And if there is a recurrence, not to leave it alone, because if it recurs multiple times, it can become malignant phylloids. So we need to sensitize them that look for any recurrence, come yearly for at least an ultrasound of the breast, and if it recurs, to report to the doctor immediately. This is another one patient we had of phylloids tumor of the breast. Discharge from the nipple is very, very common. Like I said, bloody discharge is always pathological. It could mean there is a papilloma within 2 to 3 centimeters of the nipple. If there is a palpable mass along with the nipple discharge, please do a core biopsy, because 3 to 7% of them could be DCIS, that is ductal carcinoma in situ, or there could also be an invasive component in it. Many times imaging does not show any lesion. In those cases, breast MRI with a contrast will help. Microdocectomy is the treatment of choice. This is what we do. We identify the duct from where the discharge is coming. We pass a lacrimal probe, and with the help of the lacrimal probe, the diseased duct is excised. Malignant breast lumps, 20% of them could be malignant, and our challenge is to differentiate between the benign and the malignant. Treatment options, locoregional and systemic. I'm not going in detail of all of this. In surgical techniques, radical surgeries do not have more advantage over conservation surgeries. So conservative surgeries are very, very safe, and because of the advancement in treatment, there are wonderful chemotherapy drugs available, radiation techniques available. More and more patients are doing extremely well after the treatment of breast cancer. Hence, giving a good quality of life is equally important. So not only is cancer clearance important, but also giving a good outcome so that the self-esteem of the woman is left intact is extremely important. So this is what is done. We have done a breast conservation surgery. You can see the scar is so faint and hardly seen. This is another patient on whom a breast conservation surgery has been done. The scars are not seen. So breast reconstruction and oncoplastic surgeries can be done for the lumps which are a little bigger in size. They can be done in the same sitting as sometimes when mastectomy is done. This is a scarless oncoplastic breast conservation surgery you can see. This is another patient. You can see a periareolar, there is a thin scar seen. This is post-radiation, also done probably 5 months ago. This is another patient who had a breast. This is called a donut oncoplastic surgery or Benelli's round block oncoplastic surgery. For larger tumors, we use LD flap reconstruction. This is a tumor which was seen in the upper outer quadrant. This patient had a lower quadrant tumors. You can see a flap with the skin has been placed. In the central quadrant tumors, the nipple is excised, and you can see that cosmetically both the breasts look so alike. This patient had bilateral breast lumpectomy with LD flap reconstruction. This was another with LD flap reconstruction. These were all larger tumors for which excessive surgery had to be done, and the volume had to be replaced. This is another patient. This was a lobular carcinoma which we did. This is a tram flap reconstruction. They also get a flat abdomen after doing this surgery. That's an added advantage. This is with implant-based LD flap reconstruction. This patient, we have done skin and nipple sparing mastectomy along with implant reconstruction. So the patient which I presented the case, we gave her neoadjuvant chemotherapy, downsized the disease, and did a breast conservation surgery. So we have moved away from a surgical philosophy that once aimed to remove as much as possible, to remove as much as needed and as little as possible. Another case which I would like to talk about is a 48-year-old lady, premenopausal. She did her annual screening mammogram and ultrasound of the breast. On annual screening, microcalcification was seen in the right breast, and clinically on examination, there was no lump palpable either in the breast or in the axilla. Just because she went for her health check because she was more than 40 years old, she underwent a mammogram and microcalcification was noted. So you can see this is the microcalcification. On this patient, we did a ultrasound-guided biopsy because it was non-palpable lump, and the histopathology suggested ductal carcinoma in situ, which was estrogen and receptor positive disease. So via localization and excision of the lump has been done. I would like to stress upon breast screening in this case because that's an opportunity which all of you have to educate our women. I gave you this example of the second case because of her routine mammogram, she could detect a lump as small as what we saw, which was just few millimeters in size. Had she not done the mammogram as a routine, mostly the disease would have grown, and probably by the time she came to us, it could have been metastatic. So breast screening is something which we all should understand, and that is what I would like to talk about. Breast screening has shown to decrease mortality. Early detection is the only way to reduce the burden of morbidity and mortality. The magnitude of breast cancer, yes, in our country is very high, yet it is a very treatable cancer provided it is detected early and treated appropriately. Unfortunately, more than 60% of Indian women reach the hospital when the disease is already in an advanced stage. So there have been an umpteen number of studies which have shown that when a cancer of the breast is detected on screening, the risk of death or 5-year survival and 25-year survival is higher when it is detected on screening as compared to when the lump is already palpable and the patient comes to us. Go to the next slide. If you can, go to the next slide yourself. So breast screening in India, unfortunately no definite protocol. Lump may be present even before the symptoms manifest. That is when we want to beat the cancer, because by the time the lump manifests, it is in minimum stage 2. If the size of the tumor increases, the potential to metastasize to the other organs also increases. So the aim is to catch the cancer before it is even felt as a lump, that is, to detect the disease in stage 1. And the best chance of long survival is if it is detected in stage 1. Breast is a very superficial organ, hence screening is possible. So what are the goals of breast screening? Early detection. When the disease is detected early, they tend to be node negative. In such patients, breast conservation surgery is possible. If it's a very early disease, they may not need chemotherapy. That means the cost is reduced, the duration of treatment is reduced, and most importantly, better survival rates are seen. So, as clinicians, it is our responsibility to educate people. All women who are 20 years and above, please teach them breast self-examination. Women who are 20 to 40 years of age, encourage them to get a clinical breast examination done by you once in 3 years. And women who are 40 years and above, please suggest yearly mammogram along with that clinical breast examination. So if these screening guidelines are followed, the chances of detecting the disease early are very, very high. Of course, in the West, the studies have shown that breast self-examination does not reduce mortality, but in my opinion, in Indian setup, it's very, very useful. I'm sure you will agree that there are women who come with 5 centimeters, 6 centimeters big lump, and they have not even noticed it. If only they had learnt breast self-examination and done it on them, probably they could come to us much, much earlier. So breast self-examination in our setup is extremely important, and it will certainly be useful in Indian setup. So education or awareness is the need of the hour, and screening of the breast is the only hope. So this is a study which was done when I was in Tata Memorial Hospital, that why is a specialized breast unit important? You know, breast surgeries can be done anywhere. So there was a paper which was presented in the British Journal of Surgery, and this was also a study which was done in Tata Memorial Hospital. It was shown that when breast surgeries are done in specialized breast unit, it has shown to improve survival. And breast surgery is done by surgeons not trained in breast cancer. 45% of them tend to be incomplete. 80.3% of them had residual disease nodes, and 52% were already metastatic when surgery was really not indicated. So to summarize, most of the breast problems may not be related to malignancy. Many are found incidentally on breast screening. Understanding of physical finding, imaging results, histological correlation, and management is needed to prevent under or over treatment. Most of the breast-related problems do not need any surgical intervention. Breast cancer is on rise in India. Breast conservation surgery is safe. Cancer clearance with good cosmetic outcome is possible. Survival rates in general in all stages of breast cancer are better as compared to what we saw in the past. Customized breast cancer treatment is the trend. Promote breast screening to all your patients, because early detection improves survival. So thank you very much, dear friends, for this opportunity. Thank you.
Thank you, Dr. Jayanti, for that excellent talk on breast cancer's early detection management. So now I request our ex-president, Dr. Preeti, to please come on the dais and honor Dr. Jayanti.
Thank you so much.
Thank you.